My talk today is basically one of the reasons that I joined this practice. It was, you guys have seen today, and you guys have seen today how innovative our work at the Heart Hospital is, how great it is, and I have some great mentors and teachers that I've already learned a great deal in a short period of time. And part of that is how aggressive we are, in a good way, of taking a lot of our patients that used to be specifically in the inpatient setting and bringing them to the outpatient setting. So this starts with what we do almost every day. It's a heart catheterization. And so I have a couple teachers in training who used to talk in the glory days of how they used to get access for heart catheterizations. They used to do a brachial cut down, which was Sohn's procedure, basically where they cut down on the arm, made an incision, tied off the brachial artery, accessed the artery, and then did the procedure and came back and sutured back the patient. And there was a nice workflow from what they described as far as one person did the cut down, one person did the cath, and one person closed. And so that was kind of the train of patients as they did it. I think they did about a total of 3 a day, but they did those patients and they got their information. This was actually first described by a pediatric cardiologist, Dr. Sohns, and he was doing an aortogram, and accidentally the catheter went into the artery and caused VFib arrest. He got the patient back. This was a volunteer, but that was the first clear angiography that was done of a coronary artery, and so after that, this whole process was detailed. And there's a whole school of cardiologists that were trained in the 60s and 70s with this procedure, and those were my teachers. You can imagine that this process was a little bit more cumbersome. There were a higher rate of infections, and so you saw in that previous picture how they were doing it. There were higher rates of vascular complications. These are open exposures, not necessarily cardiac thoracic surgeons that you've seen today. It's people like me who would not know how to suture, probably would have been better trained in that, but in general, that was not their forte. There was higher rates of bleeding, so you can imagine, even though you did have appropriate access and visualization afterwards, there was a higher degree of that. And in general, the biggest thing is that we've talked about it today, the radiation, the amount of how we did x-rays, how we took these pictures, and the amount of radiation exposure for both the operator and the patient was much greater. And so that has drastically changed in our procedures. So the procedure changed with a different technique called Seldinger by a doctor named Seldinger, who actually taught us how to get percutaneous access, access the needle through the skin, and get into the blood vessel without having to do a cut down. And that transformed the field and made us, and we took, in that situation, the biggest artery we could find in the body, and we took the femoral access, and that's how we started the process from the 60s to 80s. And we kind of shied away from the cut down because now you had this nice way of not having to create a big surgical incision. Eventually, the process came back to radial access. We learned that this was not required. You could use these small arteries without having to do, we didn't require such a big artery in order to get access. And the reimbursement and also the way that patients were asking for it was they did not enjoy the bed rest afterwards, the sandbags, as a lot of patients describe it to me still, post-procedure, manual compression. It's not that we don't use femoral access in this day and age. You saw the case with Dr. Sherbat this morning, that we do use femoral access, and for our peripheral cases, we still use femoral access for certain things. But when you do a diagnostic heart catheterization, you don't need to use these larger arteries or more cumbersome processes. And that's not just in cardiology. So this was taken from the NIH and just talking about hospital registries and basically saying how the revolution of basically outpatient procedures that used to be pretty much dictated where you came in the morning, you stayed the night, and spent a couple days post-op, to now where the majority of practice in medicine, not just cardiology, over 50% or close to 50% is now outpatient surgeries. And that includes eye surgeries, respiratory surgeries, obstetric surgeries, and even to that degree, for what we're talking about today, cardiac procedures. In the US in general, about 40% of patients, or 40% of all diagnostic caths are done as an outpatient. At the Heart Hospital, we are very proud of the fact that we do over 90% of our cases as an outpatient. And where did this come from? I think that was the important part. Everything that patients who are going through these experiences are nervous, are scared, who've never had one before, and they want to know that they're going to be okay after their procedures, and not just them, their family members. And this was all kind of driven by the idea of same-day discharge for patients who were going to get a procedure performed, and how quickly could we get them home, and was it within the safety reasons. And that safety was defined by patients who had major bleeding, access site complications, or death. This was, the biggest trial was a Canadian EASY trial. It was about 1,000 patients, and it actually included over about 20% of patients who actually had acute heart attacks. So more complex patients, higher amount of anticoagulation or blood thinners during their procedure, and they saw no difference in these patients that were discharged, even with those patients who had heart attacks the same day. We don't generally send patients home with heart attacks the same day, but that is what this trial was based on. And it showed that there was no primary endpoint difference in death, MI, unplanned, having to come back and look at the heart, or major bleeding or access site complications, or rehospitalization. There's a lot of other small trials, but what we do in medicine and a lot of studies when we can't find or fund a big enough trial, we do something called a meta-analysis, which groups together both randomized and observational trials. And we found in a pretty large study in 2013, about 13 studies, 111,000 patients, that there was no difference in these complexities post-procedure if you discharge the patient the same day. And so where did that come from? Well, that was the push for radial access. And so when we did this, and these studies I'm listing here are the Rival and Rifle STAS, which is basically, Rival was comparing access between radial and femoral access, and Rifle was similar, but these were patients, specifically those coming in with acute ST elevation infarcts or heart attacks. The Rival trial had 7,000 patients, all acute coronary syndromes or acute heart attacks, not necessarily having ST elevation or a total occlusion of a blood vessel. And they saw that overall there was no difference in those patients in overall mortality, or what we call MACE events, between 30 days and 1 year. But the difference, if you look at the subgroup analysis in that trial, which is just a paring down into specifically what the access site was, comparing femoral access to radial access, there was no access site complications. Now, as a caveat, these trials were set up with experienced centers. So these centers were people who were highly technically skilled at doing radial access and femoral access. And we like to think that the heart hospital is one of those places. And so this is kind of what we do in general. And so this was similar with patients who came in with STEMIs. 1,000 patients, again, all experienced radial centers, less bleeding, overall 30-day mortality, and that was driven by the fact that these patients who were coming in with acute heart attacks, getting a lot of blood thinners, a lot of medications that could increase their risk of bleeding, but when you go from a smaller artery in a smaller location, less risk of complications. Oops, wrong way. So, based on this information, our academic society, the Society for Cardiac Angiography and Intervention, in 2016 came out with a consensus statement, and that has advocated for radial utilization. It's about 13 years after I think we've utilized this here, pretty close, or 10 years at least. But available, they said that with radial access, you can use any type of anticoagulation. A lot of the studies that were concerning was if you switched from one type of blood thinner to another during your procedures, that was a concern. There was no real issues with blood hemostasis or control of that blood vessel post-procedure. So we put a little small wristband after the procedure is done. We've completed the procedure, and they have that balloon is slowly taken down until hemostasis is preserved. There's no ambulatory restrictions. I think there was a prior heart summit where a patient came in jeans, had a cath, walked out. And so that is the idea. We try not to do that with conscious sedation. We don't want them walking around. But in general, there is no ambulatory restrictions. The patient needs to use the restroom, get up, does not have to use the bedpan, can get up and walk around, go to the restroom himself or herself. There's faster recovery. In an overall sense, most patients nowadays are pretty happy and have higher patient satisfaction by doing a radial heart cath. So this is our statistics. This is just taking the last 5 years. And you can see the explosion of what we've done at the heart hospital and our clinics. And so we've taken from back in 2011, and every year incrementally, we've done more and more radial heart catheterizations. In the last year, almost 4,000 as an outpatient. Those patients were there about approximately an hour to 2 hours before the procedure, had their procedure performed, and were home within 2 hours post. How do we do? Well, since 2003, as I mentioned, we've had 32,000 selective cornea angiographies performed in our clinic cath labs. Our total related deaths, so everybody tap your table or see, if you see any wood, please hit it right now. We've had 0 deaths. So we're very proud of that fact. That includes actual interventions. In the last year, we've actually had over 100 interventions to the heart, and specifically in the cath lab, noted lesion, fixed in the cath lab, and still sent home in a couple hours post-procedure. So the transition to this is naturally our new clinic. One of our clinics that I'm particularly proud of, because I'm also there most of the time, is the Arkansas Heart Conway Clinic. We have a variety of services available at that clinic, including all the services that we would provide at our clinic across the street, next to our hospital, and any of our multiple clinics across the state. But in essence, we do have a new cath lab there as well. So we are very proud of our cath lab. We have done about 200 cases in the last 2 months there. We're very active. We can do, heart catheterizations, peripheral angiography, right heart catheterizations, just about a lot of the diagnostic stuff that you would do in a general cath lab. We have the capability to do interventions, but we are not doing them scheduled. We have the capability, if necessary, in an emergent situation, as we all are, most of us are interventional cardiologists and very comfortable to do that. So this is our clinic. This is where the transition is going from inpatient medicine to outpatient medicine. And I think Arkansas Heart Hospital has been at the forefront of that for a while now. And I think the sky, as we call it, has been catching up to what we've been doing for a long time now. So thank you. And I'll take any questions if there are any.